Well, thank you, everyone. A very good afternoon to everyone, and thank you very much for joining us on this Precision Nanomedicine Nanosystems Tea Time webinar series. I'm very pleased to introduce our speaker today, Blessing Ilochonwu. Blessing is from the University of Utrecht in the Netherlands, and she'll be talking to us about design in situ forming hydrogels. So without further ado, I will hand over live from Utrecht to Blessing, and looking forward to your presentation. Thanks very much, Blessing.
Thank you very much. Thank you very much for your introduction. I'm going to be talking about how we are using hydrogels for ocular drug delivery. We are working in Utrecht University, and I am under the supervision of Wim Hennig and Tina Vermonten. In order for you to understand a bit of what we're talking about in this presentation, I want us to show you, first of all, the anatomy of the eye. So as you can see from the picture, the eye is broadly divided into sections, so the anterior segment and the posterior segment. Generally, in order to see images, the light comes from the anterior chamber and then gets into the posterior chamber and hits the structure here, which is the retina. Basically, when it hits the retina, you have these photo cells that basically will transform the light into electrical signals that then goes to the brain and then are processed as image. In order to make drug delivery systems for the posterior segment of the eye, we have to be aware of the different barriers that are present in the eye. First of all, we have static barriers, which are the different layers of the eye and tissues. And then we have also dynamic barriers, which are the liquids and the blood the vessels that are moving all around and then hindering the movement of the eye from the movement of drugs from the anterior segment to the posterior segment. So I am part of a network which is called ocular, and we are composed of 15 PhD students. Industry are also involved in this network and different positions in academia as well. Objective that we have is really to make drug delivery system and models that will help the production of relevant therapeutics for the back of the eye. So we are really focusing mostly on the posterior segment of the eye. Why are we then focusing on the posterior segment of the eye and specifically focusing on retinal diseases? One of the major reasons is indeed that retinal diseases are one of the major causes of blindness in the Western world. And then diseases like age-related macular degeneration, diabetic retinopathy, and retinal vein occlusions are really common. As you can see from the pictures, for example, with the age-related macular degeneration, you really have the loss of central vision, and the patient really cannot see what is in front of them. While with diabetic retinopathy, we have the appearance of black spot in the vision that get gradually bigger and bigger. And in general, these diseases are chronic, and they are really due to overexpression of VEGF. That cause like the production of leaky blood vessels and weak blood vessels in the retina, specifically in the fovea close to in the macula. So when we are thinking about drug delivery system to the posterior segment of the eye, we could first think about using topical administration to deliver this drug into the eye, because it's basically what is commonly used in therapy when thinking about the eye. It has high benefit and high patient compliance, easy way of administration, and can be done at home. But the biggest disadvantage of this technique is indeed that you have very low bioavailability, as only less than 5% of the drug actually moves from the anterior chamber to the posterior segment. Another route that you could consider would be oral administration or also systemic administration, where you basically inject or take a pill. The problem here is, even though it has high patient compliance, it's not invasive, you still have the problem of low bioavailability because of these tight junctions that are present in the retina, the blood-retinal barrier. And therefore, there is no easy extravasation of drug from the blood vessels into the retina. So indeed, you are really left with in intravitreal injections that are actually already done today in clinics for people having these diseases that I mentioned before. So basically, you get a bolus injection inside the eye, and this is done frequently. Another option could be intravitreal implantations, where basically you implant a device that contains the drug inside the vitreous, and then basically over time this drug is then released. It will be the ideal situation, but the drawback of this technique is indeed that the way you put the systems inside the eye are very invasive, and also most of them are not degradable, so you would need a surgical procedure to remove them. So really the options that we are left with is intravitreal injection, but we really have to do something because of the frequency of the injections into the eye, because it comes really with risks with like retina detachment, hemorrhagic cataract, and therefore really we have to do something about that. In order to make drug delivery system in the vitreous, we have to know a little bit what is it made of. The vitreous is really situated in the posterior segment of the eye. It's a gelatinous substance composed of 99% of water, hyaluronic acid, and it's basically having a mass size, so pores that are very big, which are around 500 nanometers. And if you think about it, so small molecules can move really freely in the vitreous, while bigger molecules that are much more bigger, that are bigger than 500 nanometers, such as hydrogels, could basically be restricted in the vitreous. It's also important to see that in the eye, the vitreous is not homogeneous. You have places where it's much more dense and other places which is much more liquefied. So as you can see then, the drugs that are used are basically bevacizumab, ranibizumab, and these drugs are indeed anti-VEGF because, as I said, these drugs are basically used to contract the effect of VEGF to the retina. These drugs are already now used in clinics, as I mentioned before, by bolus injections. Other options could be small molecule drugs such as dexamethasone that are injected to treat the inflammations that are really specific to this kind of diseases. But what I want to draw your attention into is looking at the half-life in the vitreous of these drugs. You could really see that they go from a couple of days to really hours. So when you're thinking about the fact that these therapies are chronic, you can really see that we always have frequent injection when talking about anti-VEGF, in generally monthly or twice a month. And while we're talking about corticosteroids, you really see that the retention times are very, very, very low. And therefore, either you use an implant and have the risk that I described before, or basically it's really not visible as a treatment way. So therefore, this brings me really to the objective of my project at Utrecht University. We are developing an in situ forming hydrogel that will sustain this drug, could be pharmaceutical proteins or small molecule drugs for a long period of time. The target profile that we want to use is indeed using an office procedure so that the doctor, the physician can do this at home. Could do that in the office and basically or come to the home of the patient and have these injections in the eye using a small needle, something around 20 gauge needle, 30 gauge needle. This delivery system has to sustain the drug for over 3 to 6 months or even more, and it has to be a platform for not only pharmaceutical proteins that are huge, such as antibodies, but also corticosteroids. It has to be biocompatible, of course, to the eye, and it has to be biodegradable. Another future would be if this hydrogel system is mimicking a little bit the environment in which it's injected. And therefore, that's why we actually choose the hydrogels, because it will help also with the immune response and so on. Specifically as cross-linking networks, so hydrogels are a three-dimensional polymeric network that are cross-linked either by physical cross-linking or chemical cross-linking. In this case, we chose chemistry, click chemistry as a chemical cross-linker, and we basically use the de-Sider click reaction. And this reaction is really simple. It's between a maleimide and a furan group, and then it forms this ring. And this kind of reaction can really be done at body temperature in physiological environment environment, and it doesn't require a toxic catalyst. No solvents, organic solvents are used. Can be done really in water. And the added feature of this kind of reaction is really that it's reversible. Why is that? Because we can really make hydrogels that are degraded spontaneously. So after we have really released the drug, it will degrade spontaneously within the eye. So to look at the design of our system, we chose a polymer that is really present already in the eye, and that is hyaluronic acid. We did a simple chemistry by adding a furan group inside the hyaluronic acid, and then we cross-linked it with a cross-linker PEG maleimide. Mixed with the protein itself, it has basically a liquid viscose solution that can easily fit inside the syringe and then can be injected inside the eye and form this network that will encapsulate the drug within its structure and basically form a transparent hydrogel. This hydrogel was then characterized by rheological studies. With the rheological studies, we evaluated the stiffness of our hydrogel over time, and we also evaluated the gelation time. By looking at this graph, you can really see that plotting the G prime over G double prime, which means if we talk about the G prime, we're talking about how stiff our system is. And over time, we could really see the increase of this value over G double prime, showing that at around 10 to 15 minutes, you get a gelation of our hydrogel system, which means that we move from a very liquid solution into a stiff structure that has a network hydrogel. This transition is dependent on the concentration of the polymers. As you can see nicely, as we increase the concentration, we have fast gelation, and also dependent on the ratios between the two polymers, ratio 1:2, 1:5, but also dependent on the temperature. As you can really see at 37 degrees, we have faster gelling system. This is really important because we can know that we can stop the reaction, the cross-linking to happen if we just take the mixture and put it inside the fridge. Another important feature that it was important for us indeed, if we look at implantable delivery systems inside the eye, is the degradation rate. So we evaluated the degradation of our hydrogel system. And if you look at the graph in the middle, you could really see that again, that the degradation rate depends on the ratio between the polymers, but also depends on the concentrations of the polymers. We can design hydrogel systems that are degrading within a month or degrading after a year, as you can see from the graph. The system swells, and then after a certain time when it degrades, it falls apart and loses the shape and the network. Another important thing was how cytocompatible these materials are to retinal cells. So therefore, we had to do a cytocompatibility test, and we chose retinal Mueller cells. Retinal Mueller cells are really the cells that are present in the different layers of the, throughout the layers of the retina. And we basically exposed the materials, so the hydrogel system as a cross-linked network, but also the starting materials, which is the maleimide PEG and the hyaluronic acid. And we could really see that does not affect the proliferation of these cells. So another important thing for us to investigate was how visible it is to inject a liquid-like solution inside the vitreous, which is composed of 99% of water. Our fear was like, if we inject it inside the eye, would it just dissolve and do not have time to cross-link inside the eye? So what we did was to collect some fresh eyes from the slaughterhouse and then inject a fluorescently labeled polymers, our polymers, to form the hydrogel inside the eye. From this picture, you will see that basically before and after injection, you can nicely see the presence of the hydrogel where you have the green spots lighting up inside the eye. You see a localized presence of the hydrogel inside the vitreous. After 1 hour incubation at 37 degrees to mimic a little bit the physiological condition, we could basically open the eye and collect the hydrogel inside the eye. And nicely, we do something that actually has never been done, which is to separate the gel from the vitreous, and then basically look at the mechanical properties of this hydrogel system. So looking at the mechanical properties would then allow us to calculate from the elastic modulus the pores that are present inside this hydrogel, and then compare it with what we do in vitro. This is really necessary because then we could really see if we are within the range of pores that will allow the release of our proteins. For example, we are delivering bevacizumab in this present study that I'm showing you, and you see that the size it's around 6, and therefore if we compare the mass size between the gels that are done in vitro and the one that are done ex vivo, we see that there is not much difference, and therefore we are within the range, and therefore we know that our hydrogel system will release the protein only when the gel will swell further and degrade further, so it will be driven by degradation. Then it brings me to the most important question: for how long are we able to release these proteins in our in vitro studies? As you can see from this graph, we are able to make different formulations having different release rate, and we could sustain the release of bevacizumab in this case from 2 months to 4 months. I would like also to point out that the second graph is still an ongoing experiment, and that we are looking forward to see for how long are we going to sustain the release of the Avastin. Although it looks that it's plateauing, but of course probably we have to wait until the gel will degrade further to see what is the shape and the kinetics of release of this delivery system. So this brings me to the conclusion of my presentation. I hope that it was really clear that we were able to design a suitable delivery system for protein release inside the eye. We did that in Utrecht University. We are also investigating different other type of hydrogel system that will release smaller molecule drugs like corticosteroids, such as dexamethasone. We are also working not only on hydrogels, but on nanoparticles and micelles. And in our consortium, we have also virus-like particles and different type of delivery systems that will really help for the treatment of the retinal diseases. This hydrogel system, we tested it with the cytocompatibility in Queen's University, Belfast. We really looked into the toxicity on retinal Muller cells, as I showed you before. Time will not permit to show the further studies that we did, but we saw that these materials are well tolerated by retinal tissues. We did release studies, and also within our consortium and in collaboration with the industry, in this case Inocor, we collaborated with them to study how this kind of polymers and delivery system can be produced by the industry, and what are the things that we have to take into consideration, and it's actually quite a successful collaboration. In future studies, we are going to look at the pharmacokinetics of this delivery system in rabbit models and mouse models, and also we are going to look at the in vivo efficacy on relevant disease models. So I would like to thank my supervisors for their help and directions during my research here in Utrecht University, all of my colleagues, both from ocular Consortium and Queen's University Belfast. A special thanks also for Inocor, and those people were really helpful in scaling up our polymers. I would also want to invite you to join, if you're within the Benelux chapter, if you want to enjoy the benefit that comes from joining in this chapter. As you can see from the screen, you're really welcome to join. These are some of the contacts that you can use to join. Send an email to this to them, and they will basically accept you if you apply. I would also like to thank Precision Nanomedicine for allowing me to talk about my research, and all of you for your attention. And if you have any question, I will be really happy to answer.
Yeah, thanks for the presentation, and I give back to my colleague Richard to end the session.
Well, thank you very much. Thank you, Blessing, for that really interesting and stimulating presentation. That was extremely interesting, and thank you, Martin, for helping to moderate those questions as well. It's also very much appreciated. So just to wrap up, just to confirm that in 2 weeks' time, on June the 17th, there is another edition of the Tea Time webinar. This one will be something of a special edition, as it will be a global one. So everyone will be joining us in Europe, and it will actually take place half an hour later, so 3 p.m. BST, 4 p.m. CEST, and it will be presented by Ceramics, and it will be related to GMP manufacturing, presented by Dr. David Evans, their Chief Scientific Officer. So please do join us in 2 weeks' time for what promises to be a very interesting presentation. And thanks everyone again for joining us today.